So thank you again all for attending. It's my pleasure to introduce you Kathryn, Cullen, and Jessica Simacek, who are going to talk about the TeleOutreach at the Masonic Institute for the Developing Brain, expanding research approaches to understanding and improving outcomes for children and youth with behavioral health or developmental needs. And Kathryn, whom I know for a long, long time, is an exceptional colleague of ours and is one of the first people who introduced me to all this mental health computational needs area. Is an associate professor, a division head, child and adolescent psychiatry at the Department of Psychiatry. And Jessica is the director of the TeleOutreach Center. So without further ado, the podium is yours.
Thank you, Nikos. It's very nice to see you all. Thanks for inviting us to come talk today. We decided that we're going to try to keep this, kind of a overview and focused and leave some time for discussion at the end, because we do hope to illustrate some potential ways to collaborate for anyone who might be interested. So we'll talk a little bit about who we are, the Masonic Institute for the Developing Brain, or the MIDB, and then specifically within that, the TeleOutreach Center and some work groups that we have going on that involve interdisciplinary researchers and clinicians who are working towards different, important areas. And one of those that Katie and myself are both on is a work group for improving understanding and eventual treatment for non-suicidal self-injury. So we'll also talk briefly about how telehealth, ways to connect with people and deliver health or medical information, assessment, intervention via telecommunications technology has, of course, rapidly exploded in the past few years out of necessity, but it's also an increasing tool to address barriers to treatment access. So we'll talk about that a little bit, but it's also a tool we're finding that could help us reach more participants, collect different kinds of data, maybe with families or youth or children in their homes or communities. So we're also viewing teleoutreach as a tool to advance research as well. Katie will talk about some recent collaborative work that has been done with herself and Nikos and many other great collaborators using computer vision to identify behavioral markers of psychiatric illness, and how this has been applied to a preschool setting and in clinical study of children with obsessive compulsive disorder, or OCD. And then we'll also talk about some current work we have going on in teleoutreach and potential opportunities to collaborate that we've had some early discussions on. Nikos is, I should also note, part of this work group on non-suicidal self-injury, and presented to our group at our last month's meeting and got everyone thinking a lot about ways that we could potentially collaborate. I won't go into too many details because Nikos just gave us a great introduction, but I'll tell you a little bit about the Masonic Institute for the Developing Brain. This is a newly developed building that actually just opened last fall, but it's bringing together people from different departments, even colleges and clinics, and all into one place to really focus on advancing research and clinical practice to advance brain health, starting at early ages and then across youth and the lifespan. So this has been really exciting for all of us. I've collaborated some. I'm in the College of Education and Human Development and the Institute on Community Integration, and I've had the opportunity to collaborate some with the clinics, but before that would involve driving from the East Bank to the West Bank and parking and all of that. And now we're kind of all housed together. So that's wonderful. And I've been thrilled to have the opportunity to meet and get to start working with Dr. Cullen on all these other, great studies that she has going on and leads, and ways that we can kind of synergize, some work and bring together interdisciplinary connections in those areas. So the TeleOutreach Center is within the MIDB, or the Masonic Institute for the Developing Brain, and it has some programmatic areas that we focus on and developing. And then we also are starting to provide research support to other researchers at MIDB and likely more broadly in the U as well, if they'd like to incorporate tele, connections or TeleOutreach into any of their studies where it makes sense to do so. So we received a foundation donation to a gift to build out this important work and have formed these different work groups and focus areas that are ways in which we're advancing using TeleOutreach here at MIDB. One of those that I'll talk a little bit more about on the next slide, and I previously mentioned, is our interdisciplinary intervention pathways for self-injurious behavior for children and youth. So that's a wonderful work group I'll talk a little bit more about. Another work group focuses on for children who have already been identified as maybe experiencing some delays in development or some concerns. There's often a lot of barriers that they face prior to accessing intervention because there's shortages of providers, or maybe where they live, there's not providers available. So this work group focuses on ways in which to use connection or TeleOutreach to address some of those barriers to intervention access and help families and children access services faster. Another work group, and again, all of these have some overlap with each other at times, is working on, we work closely with the College of Extension to include children and youth and families from across the state. So we have a lot of plans and some current things underway with community mentees that we identified with Extension to try and take what we're doing at MIDB and work with communities across Minnesota and greater Minnesota and rural Minnesota so that they can, participate in studies going on, they can tell us their needs, and we can, co-develop things together. And then, of course, the research core, which is, these are kind of areas that we all have some work in, but then people may come to us with different ideas that they'd like to use Tele in their work. And we've set up some, processes so that we could just help support them in how they could use Tele. This is a little bit of a summary of that one work group, which again has kind of sparked a lot of what we're coming to talk to you about today. Our mission, which is, evolving. We formed last year around this time, probably. So we're about a year into this work group, but we all come together with that collective, desire to have better understanding and using that understanding to advance innovative treatment and maybe preventative treatment for self-injury in children and adolescents. And Katie will probably talk a little bit more about this in some of her slides, but one thing we've noticed in this group is we have all of these great interdisciplinary researchers and clinicians from MIDB and also from outside of MIDB, like Nikos, who've been coming together and talking about, what they study and how they study it, and then sharing that with each other so that we can learn from each other. And some things that we discover is that, the children that I might support I more often work with children with developmental disabilities. And when they engage in self-injury, it might look like, biting your arm or hitting your head against a wall or something like that. And populations that Katie works with, or that others in the work group who are in rare disease work with, it looks very different, right? It might be an adolescent who has depression, and it's not such a obvious, engagement, but it's definitely still problematic for that youth, quality of life. And so we kind of come together and share, how do we measure this? What kinds of treatment are out there? What are the gaps that are out there? And it's just a really engaging group to be a part of. And we have a lot of activities going on. And some of them are like what we're doing right now, which is reaching out to others and kind of sharing what we're up to and learning from everyone we're reaching out to, but also developing new research protocols, adding on to, kind of post-award research and gathering clinical data to kind of get the lay of the land at what self-injury looks like in the clinics. And of course, building towards sustainability through things like grant submissions and training and lots of community engagement opportunities. And like I already spoke about, the TeleOutreach Research Core is there now. It's on the MIDB website, so you can go there and access it if you'd be interested in doing so. And you fill out a form and you tell kind of the MIDB core directors what it is you're planning on doing in your study. and, what you'd like some help with. And then the research core is, we could help provide recommendations on technology, but also like kind of the how, what have other people done? How have we written some methodology to use Tele? What's been helpful, what hasn't? And then of course, things like troubleshooting, which of course come up all the time. All right, so I will go ahead at this point and switch over to Katie here.
Great, thanks so much, Jessica, for that introduction. So as Jessica mentioned, we're kind of a group that's coming together from different disciplines. And my discipline is, from the medical side, and my training is in psychiatry. And whereas Jessica's side of things has been a little bit more focused on neurodevelopmental disorders, my group tends to focus a little bit more on mental health disorders, and that's a little bit why, that's kind of the angle that I'll be sharing here. So just as an overview, mental health problems are common. About 1 in 5 people experience some type of mental health issue in their lifetime, and they frequently emerge in adolescence. And that's kind of the area, the age group that I study the most and I treat the most in my clinic. I'm speaking to you from clinic right now. Took a little break between patients to do this talk. I forgot, you have to advance the slides. So next slide. This is a slide about showing brain development, just to kind of give you a visual for what's kind of happening in the brain between birth and mid-adolescence. So what you're seeing is microscopic views of neurons, and how actually the number of neurons doesn't increase much between birth and 6 years old, but you can see it's much more dense, and it's like lots and lots of branching has occurred. So more connections between neurons. And then between 6 years old and 14 years old, there's a lot of thinning that occurs. So these are really important, really normative developmental changes that happen in childhood and adolescence. And you can kind of imagine that, like, between birth and 6 years old, we kind of develop these sort of potentials to be of our brain capabilities. And then between 6 years old and 14 years old, there's kind of more of a specialization. So like, let's say we learn certain languages or certain sports or musical instruments or just anything, like we sort of develop those brain connections that support those activities and those kinds of cognitions, and then we let others kind of go away that we're not using. So there's this pruning that happens during the adolescent period, which is also during the time of this emergence of mental health disorders. Next slide. And we think about this time of plasticity or brain change in children at childhood and adolescence as an opportunity. So when the brain is developing, we think that it is more malleable, and it's a good time for intervention, so that we might have, interventions might have a higher impact if we intervene earlier, basically. And that's kind of a rule of thumb generally for medicine. So that if you find a cancer earlier and you intervene earlier, it's a better chance of a good outcome. And the same is true for things like depression, anxiety, schizophrenia, etc. Okay, go ahead. So why can't we just do that for everyone? What are some barriers? So one, we do still have a challenge of identifying the problem in the early stages. That's one of our biggest issues. When we can identify an issue, there's poor access to mental health treatments. There's an issue where there's mental health problems have a significant stigma. So this interferes with families or individuals wanting to seek treatment because they don't want to be identified as, a person that is, mentally ill or something like that, because then that would make them not a good person or something. So stigma is a big issue. And also treatments don't always work. So there's a need to continue to advance our treatments. And in order to do that, we need to understand the illnesses better. And that motivates some of the more neuroscience focused work that we are engaged in the Institute, which is, what's happening? What is the cause? How might we intervene differently? Next slide. Great. So where we kind of started collaborating 10 or so years ago with Nikos and others was this question of, could computer vision tools be applied to look at risk for mental illness? And we kind of had this, it was partly inspired by some other research, which had one in particular that had looked at videos, home videos of kids at a birthday party. And they were able to compare the prior home videos of kids who later went on to develop schizophrenia versus home videos of kids who didn't, and there were differences. They could see little differences in these videos. So this gave this kind of things like that, gave this idea of like, well, could we use computer vision tools to identify markers of risk? And so this initial project with Nikos and others, we actually installed computer systems into the lab school at the University of Minnesota in Institute for Child Development, and implemented a bunch of techniques to track different behaviors. And the question was what to even track, but some of the things that we did, and I won't be going into this in detail, but like speed of movements, distances between individuals that could kind of like estimate social relationships, stereotypic movements. We didn't have the capability to like zero in on facial expressions actually in this set of projects, but we were really just kind of trying to develop tools to even just track movements reliably with kids and in a naturalistic setting. So that was the goal. Go ahead, Jessica. So this was like more foundational work. We were studying healthy kids, not ones with psychiatric disorders. So we didn't have longitudinal follow-up. So it's possible that some of those kids went on to develop mental health disorders, but we wouldn't be able to like go back and track, what we found with the video and what happens to them later. That we realized there were some challenges with tracking movements in an unconstrained situation. And some of our students actually on the project developed little side projects where they're like, okay, let's create more constrained situations where we can get a certain like movement or elicit a movement in a certain situation and really capture it well on video. Next slide. So some of the a vision of this work, I guess, number one, just as a set of next steps, building off what we did with the preschool work, was maybe number one, apply the tools in a patient population and try to refine the tools for really kind of starting to identify like subtleties in patients with mental health problems. So, because sometimes these things are not really overt, and we want to be able to appreciate subtle abnormalities. And then and that's kind of like, oh, that's as far as we've gotten right now, number one. But once we had the idea is once we kind of had those refined tools, we'd be able to apply them in a high risk sample and do longitudinal studies. So that's kind of like a future aim for this type of work, which I think could be really high impact, but it's, we've got a ways to go. And then ultimately bringing refined tools to broad community sections to enhance early detection. So, but before we can do that, we have to at least demonstrate that it can detect future mental health issues in a high risk population. Next slide. So I told you we only got as far as step one. So we started to apply some of the tools in a high risk population, and a sample of kids that we knew had a disorder. So we started with obsessive compulsive disorder, and one of my colleagues, Gail Bernstein, is an expert in obsessive compulsive disorder. And so we invited some of the kids from her other research studies in her clinic to participate, as well as some healthy children. And we did a couple of things. One was we had them do like a couple of different tasks. One was a free arrangement of items. We gave them a bunch of like objects and asked them to just arrange on a table how you want. And then another one was hand washing. So I'll go through the results of those two tasks. Go ahead, Jessica. Thank you. So for the free arrangement, again, we were kind of interested in the idea of like clutter and like environment, and this was a collaboration with somebody from the college, a couple of different people from the College of Design and Architecture. So we had kids sit at a desk, they had these items, and they were just told to organize. And we found a couple of just interesting things. So the OCD group used less space in the free arrangement tasks and the healthy controls. And we found that severity of symptoms correlated with symptom severity, or severity of their arrangement time, excuse me, the time that it took for them to arrange the items correlated with their symptom severity. So just an example of how like things that we can gather from a video of just an everyday task might correlate with symptoms and with psychopathology. Next slide. The other task we had was hand washing. So hand washing is kind of a classic OCD symptom where kids might get, or adults might be worried about germs and then excessively wash hands. So we actually created a lab in which there was like a toilet, it's a fake toilet, and a sink, and they were instructed to wash their hands. And we rated a bunch of different things with the videos. And the two of the key findings were that, in fact, as you would expect, hand washing time was related to OCD symptom severity. So that was nice to see that we could capture that with the video data. And also, we also picked up that there were these other behaviors that kids were doing that had OCD that like weren't necessarily longer washing, but just other unusual behaviors like tapping or touching the sink or investigating the area, or different things that the kids without without OCD didn't do. So it just it's an example of like, you know, sometimes these video coding approaches can reveal something new about the disorder that you wouldn't have thought to look for. Next slide. Okay, so I think I switched to you now, Jessica.
Let me get my sound back on. Thank you so much, Katie. That was great. And I'll try and keep that same pace. I thought that was wonderful. So I'll talk a little bit about some of the ongoing or kind of current opportunities that we have going on. At least ones that we've talked about already. There's obviously lots of opportunities out there. But one thing I wanted to point out is that as we've been helping, you know, different researchers figure out what kind of teleoutreach modality may be helpful to different types of data that they might want to collect, or clinicians for what kinds of ways to help support children, youth, and families better. We talked a little bit about there's like different modalities that this can be provided with, you know, which you're likely well aware of most of these because they've become a lot more commonplace the last couple of years. And of course, these modalities can be combined together. And why that's important is that, you know, we would never suggest replacing, you know, data collection process or some kind of clinical service that's better delivered in person with Tele. That wouldn't be a good, you know, thing to do. But are there ways in which you could collect new data, more frequent data, or reach a child and family, you know, in a better, more efficient kind of a way? And so that'll be kind of in relevance to some of the things I was going to talk through. So there's synchronous, which would be kind of that live video feed, where, you know, like we're all probably very used to, you're on a Zoom call with your doctor, right? That's kind of the way that a synchronous call would work. Oftentimes you'd have audio and video, unless there's a bandwidth issue or something like that. But there's also asynchronous, where there's more of like a store and forward process, where let's say I was researching children their communication, and I wanted a family to send me a sample of their speech at, you know, 4 o'clock, 5 o'clock, and 6 o'clock, because those were different important time points, you know, for a week straight or something like that. I could have them record that and upload it to a secure platform, and then review it later. And then again, if it's some type of intervention study, I could listen to it. You know, we could record how many times a communication act happened, and then provide some feedback to the family. So that would be like an asynchronous connection. There's also remote monitoring, where you could layer in some different ways to monitor, which, you know, could be bio, but could also be like cameras or things like that. And then mHealth would be messaging, which would often be applied to like an at-risk population. So a good example here would be if someone opted in and said it was okay Somebody who might have asthma and is more susceptible to the flu could maybe receive, messages to remind them to get their flu shot. And here's the links to the sites and, some stats about why that's good or something like that. Now, again, these things can be combined together, but there's a lot of different ways to collect this type of information or to provide services. And one of the ways we've been using it is a research project that's been going through several iterations over about 6 or so years, I guess, at this point now, which is improving rapid access to early intervention for children with neurodevelopmental disabilities. And kind of like Katie gave, I'll just give you a very, very brief background to why this is an issue in Minnesota, but of course also nationally. In fact, Minnesota does better than many states in this area, but still not good enough. So for neurodevelopmental disabilities like autism spectrum disorder, those can be identified very reliably by 18 months old. And like Katie already said, when a child is identified as having autism or related neurodevelopmental disabilities, that early intervention is really critical to help them start to communicate if they're not communicating, and to support them and to support their family. But even though it can be identified pretty early, most frequently it's not identified, and the average is more around 4 years old. Reasons for this is there's a lot of wait times for that evaluation. Some of the reasons come from the detection part, like Katie was talking about, but autism is now screened for, pretty regularly. But even what a parent or a pediatrician or an educator identifies, this child has some delays in development that we're concerned about, or we're seeing some kind of like red flags, and they refer them to that evaluation. Starting then, and this is kind of a low estimate, like a 6 to 12 month wait for that initial evaluation, which can be longer than that. Why that's important is the child needs to receive that diagnosis to access early intensive behavioral intervention, which is kind of the gold standard of treatment or of support and intervention for children with autism and related neurodevelopmental disabilities. And then there's a lot of health disparities that are created because families who are in more rural areas experience longer waits, have to travel further distances because there's not that many places to go for an evaluation like this. A lot of them are in the metro. And culturally and linguistically diverse populations are also diagnosed later, which again perpetuates health disparities because then they're going that much longer before accessing intervention. Once a child does receive the diagnosis, there's usually another period of waiting because there's also a shortage of early intervention providers. And so in all this wait can last from 9 months to 3 years before that time that child's been identified that they could benefit from intervention to when they receive it. This is a really nice map that my colleague and co-director, Adele Dimian, put together actually for her dissertation. And it just depicts the different counties in Minnesota. It's kind of like a heat map. And from when that child received their diagnostic, looking at diagnostic codes in Medicaid system, when they received their diagnosis and the amount of months that lapsed before they received intervention. And the darker shades are longer waits. And then the little kind of the size of the dot in the county is how many children, or the size of the sample that was recruited from. And so you see it, across the state, and there's some limitations here that when they were in areas that, they weren't accessing, there were too small of numbers, it wasn't reported, but overall, children are waiting quite a long time. And at the time when she did this, it was 9 months on average. So it's a big problem. So one thing that we've focused a lot on, myself and my colleague Adele and others on our team, is ways that we could connect via Tele to support caregivers and some caregiver coaching via that kind of synchronous live Zoom, connection, and coach that caregiver through some communication skills with their child and through any challenging behavior that might be occurring. Young children with developmental disabilities, especially when they're not verbally communicating, may engage in challenging behavior such as aggression or self-injury. And oftentimes the treatment or the way to improve that is to teach communication skills that they can use. So sometimes that's, frustration of not being able to communicate. So those are really important things to work on. But one thing I'd like to point out about what we've put together and been studying here and seen some, success with is that we really view this as like a supplement. So it wouldn't replace what that family was going on to receive. You know, hopefully long-term, maybe it would reduce it, maybe not. We don't know. We have a study going on right now looking at that. But it definitely provides them with that support sooner. And so, we've been able to teach some communication skills that way. So we've taken a lot of those data, and we were recently funded to do, you know, a larger scale RCT that really is trying to reach children can be included from across Minnesota and other states, but we're really trying to oversample and reach children in rural locations and from culturally and linguistically diverse groups to participate. And then we have planned long-term follow-ups to look at just that, not just what's kind of, you know, their immediate outcome, but what are some of those distal, you know, outcomes as well in terms of the child and their communication or challenging behavior or, you know, quality of life. And then also the family, if the family feels supported and feelings of kind of efficacy and reduced stress. And so we don't know the findings of that yet. It's currently underway. But as we've talked about this study, and as I've watched some other studies, you know, come out about using telehealth in that kind of a manner, some people are starting to publish studies on how switching their studies to tele, you know, protocols has helped to increase enrollment, reach low, you know, incidence populations. You know, they don't require that travel component, or they might be able to reduce some travel. And so that's going to, you know, of course, save, you know, grant budgets, but also just save that kind of burden on having someone come back for, you know, additional visits, but still be able to kind of increase that data density and get more time points. The caveat I had up here is, which all of us are probably well aware of, when something is purely like online module type based and there's no like, you know, I don't know, quiz or like feedback from somebody, they're usually the completion rate's pretty low. So that is another finding that's out there, that it's nice to have some connection to help people increase watching, like parent ed. In my world, that would be like parent education modules. Parents want to learn and they love their kids, but they don't always have a lot of time to just on their own go watch videos. But if you give them some instruction and support and follow up on doing so, then they're more likely to do it. And it can also, again, which is really important to the type of research I do, help us collect data in those naturalistic settings. So children and families in their home environments. And we've used it in some examples to help on multi-site studies that are large and do involve participants traveling to a study site. We helped add on a measure from an additional grant to a large, you know, study that was a network. And for that one measure, it's a home-based measure. It's an interview with a parent and a caregiver in the home, or sorry, with a caregiver and a youth in their home. We collect that measure here at the U for that entire network, which is kind of fun. But there are definitely limitations to this approach, and the limitations go beyond what I have here. But the ones that we wanted to present to you and kind of bring forth is that one thing that's really important, especially when you're working with children with developmental disabilities, is differences in eye gaze patterns, that joint attention, or kind of that interaction with the caregiver. So that shifting of attention with a caregiver between, oh, look at that birdie, and being able to kind of reference what the caregiver was talking about and share in that interaction with them. It's a very important skill, you know, set for child development. And it's also an area that's very impacted for children with autism spectrum disorder. And so it's really important. It's really important to be able to measure that in these kinds of studies. And we have not to date been able to find a great way to measure that type of a measure. I'll show you a video in a second to demonstrate this. So that's something that we'd really invite a lot of collaboration on. And then that kind of you're balancing wanting to collect really high quality data with the fact that we're sending out kits to families in their homes. So we can only make it so complex because they're going to have to set it up and get the audio right. And should we have a, you know, external mic, or should we use the built-in one? Should we use one camera? Should we try to set up two? And of course, as you're likely all aware, you know, on this call, everything you kind of layer on is one more thing that can go wrong or not work. So this we'll just watch for a minute and trying to be mindful of time. But this will show, this is the type of session. We of course have permission to share this. This is not an actual research participant, it's modeling the procedures. But this is showing exactly what the types of sessions and the kind of data that we collect look like. So it's a family in their home. We do try some positioning with the camera so that we can capture both the caregiver and the child in most of the interactions, knowing that, of course, kids are going to move around. And we try to kind of get it in a place where they can kind of set it and forget it, so they don't have to keep moving it, because we really want them being able to interact with their child. Okay.
All right, that looks great, guys. So
can you hear it?
Play for a minute here, and I'll let you know when we'll move on to our next session. Look, it's purple. Wow, that's a good color. I like that purple. That's a dinosaur. Oh, where's the dinosaur? I don't know. I don't know either. Oh, okay, Jessica.
So a couple of things while we were watching that, there were several times where the caregiver's kind of making bids for the child's attention, right? Saying like, oh, that's so nice. I like that coloring, or, whatever, talking about things. And one thing I think we talked with you, Nikos, about, and Assad, was that there's different time points where the child is actually facing the caregiver. So you can see that they're kind of facing each other, but her eyes do not seem to go up at all and gaze at the caregiver, right? So she's responding and they're facing each other, but we're not seeing that gaze kind of shifting. So anyways, just thought I'd show that. So that brings us to some long-term research, questions or thoughts on ways that we could potentially collaborate. And again, a lot of the things I'll talk about are about these specific videos and examples, but of course there's other things that you can of course capture via Tele. But if there was some way to automate, right now those data, we have, online systems to do this, but they're hand coded, right? They're coded by trained graduate research assistants, and we establish reliability. But for things like joint attention or gaze, the way we have to operationally define and measure that is very limited. We can't usually measure actual gaze, and instead we have to measure kind of orienting. So that's why we usually have our camera to the side so we can see if there's movement and the child's orienting. But like you just saw, that child was oriented for a lot of that segment, but was not also looking up or shifting attention along with the caregiver. So if there were ways to automate that, would we be able to do that in a way where we could capture those data better? Are there differences in error, in the feasibility of being able to do that? Coding for those kinds of things is very difficult to get reliable on. So things that are really discrete and obvious, like a hit or a word or whatever, those can be easier to code. But things like this that are really nuanced can take a lot of person time, of training and reliability establishing to get reliable. So would there be differences in the kind of the feasibility of being able to do that? And then just on the very basic level, what would be good setups? Some things we've talked about was if we added a second camera and had kind of a standard place where we asked them to place it, would that help us capture more? And then of course, the longer term goal that all that would feed towards is if we could collect data in those types of a way where it's, automated to some degree, could then that help us serve as an outcome variable for treatment effectiveness, where we could see if there are changes in this type of behavior, or like Katie had noted, that maybe there's something else happening or other patterns that we're not even measuring because we're not picking up on them.
Question?
Yeah.
If the caregiver is on the on the other side of the teleconferencing, not sitting in front of her, do you guys envision to do that?
Probably not at this point for these kids. We really try to, minimize we call it like the coach or whatever, the interventionist who's coaching the caregiver, to try to have the child playing with their caregiver, interacting with their caregiver in their home. Potentially with kids that were a little older, or maybe as a research, as a way to measure, if that's a better way to measure. As an intervention, we obviously probably wouldn't do that, but yeah, if you have ideas on that, that would be great.
Maybe because at that age, they're not communicative enough.
Yeah.
But the idea is that if you have a camera and you're communicating through the camera, you
Mhm.
are able to capture their facial features. You're able to capture even gaze sometimes.
Okay.
And it's just like imagining that if I have a camera on the caregiver
Mhm.
looking at the kid, because frontal face is much better to understand what's going on than side, profile base.
All right.
So
Well,
so the more frontal it is, the better understanding you're going to get. The better resolution, the better hunting for the gaze and understanding what's going on.
that's really helpful. Yeah, and I mean, I think there's no reason we couldn't do that for to measure some. I mean, with the young kids, it would be hard, but
Because I don't know if you guys do telemedicine, because in telemedicine with virtual, you get on the camera and then you talk to the doctor and you tell him what's going on and things like this. So typically the camera is right on frontal and you are able to kind of monitor the expressions and how he's talking, what she is talking, right? So those will be somewhat beneficial. And you can tell if the person, in a way, if they're looking at you or if they're looking elsewhere, right?
Yeah, I mean, and
It
there's
might be
also
a trial, I would say, to kind of.
I mean, we could also, at least, for, looking at them doing that with the the parent helps them look at the interventionist. It wouldn't be the same as parent because they probably have, that would mean something a little different, but at least to try it out, we could always try that.
Because what I mean, if I look at this video, the important person is the kid. And if you can monitor the kid better, it will be more informative, right? So having a camera behind the person might give you a better understanding, possibly.
Okay.
I will just add that as a psychiatrist, telemedicine works well with some people and not well with others.
Yeah.
And it works really well if a person is willing to sit in front of a camera and talk to that camera. And if they're not, then they're off in the room under a blanket, then it doesn't really work.
Yeah.
So sometimes with these 2- and 3-year-olds, it is more challenging to get them to focus on something.
Yeah, it'd have to be short. It would have to be really.
It would work really well with some people, definitely.
Yeah.
But with my patients who are teenagers, they do it much better for the most part.
Well, that's good to think about then. All
Yeah.
right, well, that's helpful. I took some notes on that.
Yeah, thank you, Saad. So I would like to kind of move through because we want to have time to have a couple more questions. My work is on adolescents with depression and self-injury. I'm really passionate about this. Suicide in adolescence is the second cause of death, and it's a tragedy that I think we all want to prevent. And it is potentially preventable in a lot of cases. It's associated with depression, and having a history of self-injury, even when it's not associated with a suicidal intention, is also a risk factor for having a future suicide attempt. So there is some overlap. So studying depression and self-injury has been a focus of mine in my lab. Next slide. And what are some of the things that we might be interested in? Saad and I were talking about this earlier this week. We're definitely, of course, interested in facial expressions, and we're interested in subtleties, posture. There's a certain posture that people take when they're more depressed, qualities of voice and social interactions. And I briefly was reviewing literature to kind of provide some examples. So I'll just fly through these, Jessica. The next slide, this is an older study over 10 years ago now, but an automated facial action coding system. So ways to, I don't know if this is what you were telling me about. Saad was telling me more about like a mesh approach, but these are strategies to track facial expressions that have been developed and have been out there for a while. Next slide. And ways to track pain. This one is focusing on pain. So looking at like brow furrowing, lid tightening. So very more like a little bit more subtle expression changes that can be tracked automatically and relate to things like pain in this example and deception and different things that may be of interest to us as well in our work. Next slide. And there's been some other work looking at depression severity and relation to certain things like number of smiles and expressions of contempt. A paper showed that that there was relationships with velocity of head motion and amplitude. Next slide. And also looking at actually the qualities of the sound. Is an area of interest, which I haven't done at all, but I think would be really, really relevant. So taking some computational approaches to look at like unconstrained conversational speech and like things like vowel space, for example, have been found to be associated with some psychopathology. Next slide. I raced through so that we could conclude and just have a few minutes for discussion, because I think, are we supposed to end at 3:30, Nikos? Or Ray?
Yeah, I think it's about, if we go a little bit over, it's no worries.
Okay.
Yeah,
great.
we can go a little bit, over.
Okay, great. I just didn't want us to be like talking to the end and then not have any time for questions. So I'll just conclude by saying, mental health problems are highly prevalent. They typically do emerge before adulthood. And certainly this is the case with the neurodevelopmental disorders that Jessica studies. We really feel strongly that early intervention is the best hope for optimizing outcomes. And so this is why we're really trying to think outside the box and looking for tools that might maybe, for example, potentially collaborations with people in your group, using computer vision tools to identify behaviors that signify risk or track the progress and treatment response to interventions. So I think this is just an overview of what we're doing, and we just wanted to kind of introduce ourselves to this group and invite conversation and potential collaboration. So maybe Jessica, if you want to go ahead and maybe show our acknowledgements, but then we can just stop sharing and see if people have any questions for discussion. Thanks to everybody for staying to the end as well.
Yes, thank you.
So hi, Katie, this is Vasilios. How are you?
Hi, good to see you or hear you.
Okay, let me just turn my camera on here.
Long
So
camera.
I know we're in a discovery phase, okay, but are there any longitudinal data that will justify one approach or multiple sensing objectives that we listed here?
Mm-hmm. I think you're right. I think we're in the discovery phase. In terms of mental health, I think there's not longitudinal data that I'm aware of. It's mostly still in the cross-sectional area. So really trying to find and applying it to patients that already have an illness to even say, like, can we detect things that are relevant? So then the next phase being like that longitudinal prediction. Jessica, what about you? Is there anything in the developmental disorders that would be longitudinal as yet, or is it still kind of too early?
Well, not necessarily data I for sure have access to, but there are sometimes there's a longitudinal study that I'm on that collects that extra measure, and there'll be studies of infant siblings of children who have autism because they're at a higher likelihood of also going on to develop autism. So there's several different, like they'll call them like the baby SIBS projects and things like that, that are international, and there's several in the US. I don't, they wouldn't have necessarily been collected in this way, but there might have some video of
eye gaze and things like that.
Yeah, they
Yeah.
do, yeah.
And whether they can do mirroring, it seems like that's been studied in autism siblings.
Yeah, and I mean, Jed Elison collects eye gaze. I don't know like for what, if it's how long it's been collected for, but where they'll look at different, tasks with like a Toby, eye reader or gaze reader. Those are the ones I can think of. I mean, we have a lot of video data from the Tele sessions, but it wouldn't, we hope to have some longitudinal data eventually, but right now we wouldn't. Yeah, the baby SIBS projects do also collect on typically developing controls. So, and then I think they also have children with Down syndrome, or children who are siblings of children with Down syndrome. That's another comparison group.
So from the data that you have already collected, is it possible to is there a big variability in a specific type of behavioral data, for example, that exists between all the collected data from all the different individuals that we have at your disposal? So how big is the variability, the variance in the data? I mean, do the variants show that it's very difficult to use this as a particular measure of distinguish between certain cases or not? Have you reached that point?
Yeah, so the way we've been currently measuring it in terms of like eye gaze, joint attention, we just can't really measure it. So we'll try and code for orienting and things like that. So we haven't found a good way to code it in terms of how big and how variable. Most of the kids we've seen are 12 or under and have a diagnosis of autism, and we take them through different tasks or activities like snack time, those kinds of things. But I don't know that any of our camera angles, unfortunately, are going to be, a lot of them are like the one you just saw. So it'll be more from the side, more kind of raised up, single camera. So I don't know how useful they'll be, unfortunately, but yeah.
Yeah, so one idea might be just using those small now robots that have cameras in them, and they can escort somehow or track the kids and basically collect all this data.
Yes, that's a great idea. Like because of what I said earlier, that like they won't necessarily sit there and look at the camera, so could a robot follow them around? Yeah.
And I work with some people from, I think from your department. Do you know Renata Chica and Miriam Mahmoudi?
Yeah, Miriam is helping with a meta-analysis we have going on in self-injury.
So we basically put some project together for using now robots for like a social tool for interacting with people with certain disabilities. Now the same idea can be applied, of course, to the case of kids with autism spectrum disorders and other things. So by presenting stimuli, tracking in one system the eye gaze, the attention and all of that stuff. So
great.
That's really cool. Thank you.
Thank you for your presentation. It was really nice.
Thanks for being here. Anybody else have questions? Saad, you have a question, but we can't hear you.
For the depression, so we know that micro expressions play a big role versus the long-term expressions. But have you looked at pulse rates and galvanic sensing and all the other types that you can extract when you're talking to these kids? Because galvanic sensing has a lot of information when you're trying to react. So it's usually used also for deception, right? So when you have the pulse, when you have these, and then you get the micro expressions, is there something there with this multi-sensor? Just like speech might be giving you some information about segmentation of these things. Did you look into, seeing a change in heart rate or a change in galvanic sensing that might give you some indicators?
Good question. Yeah, I mean, I haven't looked at it from that angle. A while back, we had a project looking at like some of the like electroderm responses to threat. So we were specifically looking at like how physiological responses to threat. And I had a specific collaborator who was really interested in that. And then he left the university. So it hasn't been as much of a strength, but actually, Jessica, do people at our institute have any like electrophysiology labs looking at like these skin responses? Because it is fairly intensive, you need like a fair amount of equipment and things to do that. And it is really interesting. For adolescents with non-suicidal self-injury, interestingly, I think I told you, Saad, when we talked, that they have a weird signal in their cortisol, their salivary cortisol responses. So whereas normally you would expect they would have like off the charts cortisol responses to stress, they actually have this flattened response. So they have this, like, they look really stressed in the context of a stressor, like a speech, giving a speech, and they say they feel really stressed, but their cortisol is flat. And also and other people who have these labs have found that their galvanic skin response is also on the flat side. So they have physiologically they're dampened, but other aspects of like their brain response is still active in their feelings. So that's the kind of thing we've been looking at, but I haven't like tried to correlate that with video as yet, but it's an interesting idea.
It's mostly what can you get from a wearable that you will be able to use in your analysis. So we don't want to kind of intrude. It's anything that is non-intrusive, acceptable to them, that you'll be able to capture and then analyze later.
Yeah. So like, you mean like a wristwatch thing?
Yep.
Yeah. That would be super cool. I'm also interested in, and I have not done that, but I'm interested in that. I haven't, there's something, heart rate is interesting, and also heart rate variability seems to be really relevant to these stress disorders, where like having a lower heart rate variability is a sign of
no response.
Not being very resilient.
Thank you.
Yes, thank you.
Yeah, just following Dr. Simacek, that was an absolutely fascinating presentation. Thank you. I'm part of the core group that's planning the Health Discovery Hub, and we've been told several times that the MIDB operation is a model for two things. One is the interaction of people from different fields, but also because in the Health Discovery Hub, there's going to be a tremendous focus on the outreach and clinical trials across Minnesota. And I'm on the group because I also direct the Medical Devices Center, and so that'll be our new home come 2025. So I want to follow up with you, both of you, later. So be expecting an email. My question is in the remote monitoring side, in particular the case where stuff is left in the people's homes, and what you found is the acceptance or barrier to that. But beyond the setting it up stuff, I've done some things in the homes and completely resonate with the setting up business. But the idea and the willingness of people to have things in their homes for extended periods of time, and particularly cameras in their homes for extended periods of time, and the times when they're not doing, synchronous telehealth sessions.
Yeah, so it's definitely an area where there's those, and then there's things like Lena recorders, which are like voice recorders. You can kind of put in little overalls for kids and it will record for 2.5 days until it runs out of batteries or whatever. And then it shuts down and then they mail it back and you can, you know, extract the data. And so I'll kind of lean on some of that because I haven't like set up a camera in a home and not had some connection with the family. But I know another group that was doing a smart home technology design, you know, with adults with disabilities was saying that, you know, lots of times right now, unfortunately, you think smart home technology is being used to like help increase people's autonomy and independence and have to have as many folks come into their house, but sometimes it, you know, feels more like watching you and, you know, whatever. So that's more in practice. But I know with the Lenas, which again is sort of similar to the video, is one thing that's important is they keep a diary. I think it's for families that opt in and say, yes, we're willing to have you record, because it of course records their interactions with their child. That's one of the primary DVs that you can extract from it, is the number of back and forth communications with the child and the parent. Some things that help make people more comfortable with it is that they'll kind of keep a diary, and then if they're like, delete out anything from 7:30 to 8 or whatever, no questions asked, whatever, you get a phone call, who knows, that can make people more comfortable in consenting, is that ability to kind of say, for whatever reason, don't use, you know, this audio time frame. So I would assume you could maybe do something similar with video, or if they had an opt-out button, like I know when we do Tele, we do a lot of coaching on, we know you're in your homes if we're synchronous, you know, and grandma might come to the door, or you might get a phone call, or you need to go do something. So this is how you mute, this is how you turn off. You can tell us to disconnect and we'll reconnect later, just so that, like, to help them kind of protect their own feelings of privacy. So we do a lot of kind of coaching on that, you know, put a little post-it note up that we're recording. So if someone else comes home that wasn't there before, they're going to know that there's a video going and there's researchers on the other end. So we'll do those, which again, I know doesn't fully answer your question, but those things do seem to make people more comfortable with using the technology, and could maybe be applied to like a video that's just going to run and you're not going to necessarily, you know, be there. So that would be, I guess, the initial.
Okay. Yeah, thanks. Appreciate that.
I mean, honestly, I would say, you know, again, this is probably like bias of the people who end up reaching out to us, but we always will kind of go in this deep explanation as why we're recording and whatever. And everyone's always like, yeah, whatever, just record it. Like, nobody cares. So again, maybe that's the type of folks who want to participate in a telehealth study, but we haven't really run into that too much. Yeah. The one thing that would probably be, you know, you'll come across a lot in what you're doing and probably already do, is that bandwidth has improved a lot, but sometimes we do need to send hotspots or tech kits to people to get connected and be connected, or an Ethernet cord every once in a while when we're connecting with families that might be in like on the North Shore, or in like Wisconsin, like north. We've had some families in kind of like Wisconsin's North Shore, and connectivity isn't always as good. So yeah.
Other questions?
So I have a question.
Yes.
So what do you think is the biggest computational challenge? What, so for example, what will be a game changer for you from a computational point of view? What, to rephrase it, is there something you say, I wish I have had this tool?
Well, I definitely know on our end that we have spent so many hours trying to code things like joint attention. And if there was some way to help code that more reliably, you know, more feasibly with less kind of training time, that would be something that would be a game changer, I would think, because for research that's involving young children who have developmental disabilities, we're always going to be limited in tele measures if we can't. They're going to have to come to some kind of in-person, you know, visit to get that type of a measure right where things stand right now. So that's a big limiter for us, and then I would also assume for clinical practice too.
Thank you.
Katie, what about you?
I think it's a great question, and I think I need to think about it some more. I think I'm still in the phase of trying to figure out what is my most burning question for this type of work. I think I mentioned I'm interested in these subtle face expressions, micro expressions. I'm interested in subtleties of voice, and so I guess finding ways to detect those signals, even with low-tech interventions, like that don't require a fancy lab, that can be detected with, a kid's cell phone or something like that, would be, and to do it reliably. I think, Vasilios asked earlier, like, what's the variance, and we're probably like nowhere near like ready to answer that question and have the tools to know, like, is this even worthwhile? Because can we precisely predict behavior based on this data? But because we don't even have the data yet, and we so I think my most I'm still in the I think we're still in the phase of, can we collect some relevant data reliably with the tools that we have is still kind of an early stage question.
The challenge with the micro expressions, I mean, for the regular expressions with these facial action coding units, that the smile means that this is up and this is down, or whatever it is, right? So surprise is your eyebrows are going up. The challenge on your side is with these subtle expressions. What are those subtle expressions, and how do you connect them to the depression level is very challenging.
Mm-hmm.
So, and I think the first step is, can we extract these micro expressions? And then the challenge will be, how are you going to relate them to whatever is the class of interest that you have?
Mm-hmm. Yeah, because I think it also depends on the application, because like, I think there's kids that have depression who are actively crying and saying, I feel sad, and we don't need any fancy tools to get them the help they need. They have tears flowing down their face. They're saying, I'm sad. We can get them an appointment. But there's also kids who don't show that, and who they keep it on the inside. They wear a mask of a happy mask, or just at least a neutral mask. But there may be ways to detect that, that teachers could use to kind of be like, this kid is at risk. Like, let's send this kid to the counselor to at least just ask some questions. So that type of thing would be of interest, I think, if we get there, which is a little bit of a ways.
Yes.
Victoria, did you have a question?
Well, no, I mean, I was just here to see if there was anything that like virtual or augmented reality could potentially offer. Maybe not so much for the monitoring in the Tele case, but the VR as an augmented reality, occupies this really interesting space in between real and not real that affords some sort of fascinating possibilities, because on the one hand your mind knows it's not real, but then the primitive part of your brain sort of still has these reactions as if it was real. And so anyway, I don't know if it maybe just
I wonder if we could it's this idea of wanting, like when we started out in the lab school work and wanting to collect data in naturalistic settings, but then realizing there is a challenge to that, and there's ways that we want to kind of elicit certain things, and it's in a way it is a strategy for eliciting a reaction or a behavior by creating a situation. Certainly we can. I haven't used VR other than like my collaborations with Nikos' students and yours, but you can imagine it could be, we could create a situation that would elicit a feeling of sadness or a feeling of threat or a feeling of, self-empowerment or something that we'd want to try to measure their face and their voice and in response to it.
Yeah, I mean, there's all sorts of things that people are doing with VR from that, the exposure response, and also, like say, training, situational training, point of view training, just all sorts of interesting possibilities. So just to, I just wanted to show up and say that, we're here if anything ever comes to mind that you think like, oh, like VR might be cool, you know who to call.
Yeah, thank you for saying that. I think, Jessica, we should brainstorm that, like if we have some questions.
I think that I was just thinking through some things. I guess maybe not as much for like the little kids, but for the older. I have a 14-year-old and she does whatever, they do whatever the version of VR type stuff you can do at home is now. And they talk about jump scares. So they play these games.
Yes.
And like, it's like jump scare, like something pops out at you or something. That's what came to mind.
So the reaction of these kids when they are in a different world might be different when they're sitting in front of you. And the idea is that, let's say that if I'm very afraid of heights, and if I put you on, the top of the mountain, and you're trying to kind of tell you that, and you're asking me questions, I might react differently than if I'm sitting in a chair. So, moving these people in these different locations. So what do you call people who are afraid of being in a box or something like that?
Claustrophobic, right?
Claustrophobic. I mean, if you're putting me in a room which is very small, very low light and things like that, I might react differently. So isn't there, and then if you're monitoring this person when you're asking him questions and you're putting him in these different places, wouldn't this be beneficial to kind of assess the problem, the mental health problem that they have? So let's say, a soldier who is kind of afraid of heights, they try to kind of get in him step by step to do it. But instead of him going and put him at 8,000 feet, they can put him in one of those things that, you push air and then they train with the VR. That's what they're doing now to kind of overcome it.
Yeah, what people have found is that there's sort of a higher uptake on the VR because people know it's not real, but it's real enough that it gets that you can get a response from it, but it's not so real that people just kind of shut down and say, no, I'm not interested in pushing myself on this.
So it's like in between.
Exactly. It's that funny in-between space where it's not real, but you still sort of react at an instinctive level as if it was real. And so there's all sorts of interesting potential that you can do in that sort of, funny in-between space. And that's what a bunch of us in the VR community are really interested in trying to understand, like, how does virtual reality differ from real reality?
So Vicky, doesn't your subconscious act as it is real?
Well, yeah. So like the best example is we have this demo in our lab, which is like the pit room. So we have people walk across that we have a virtual reality simulation of our room. So people walk across the VR real room, and then they have to follow this path, and we calculate skin response, step width, step everything, and then we drop the floor and they do the same thing. They walk on the same exact path, except that on the side of the path now, instead of more floor, there's like a hole in which you see like a room below and a room below that and a room below that, and people, some people will just like press themselves against the wall and not walk, and some people will walk with anyway, but it's interesting because you watch other people do it, like when we do these demos, like the first one or two have this really big reaction, and then the next like 3 or 4 or 5 are just like running across. And if it was a real plank across a real gap, I don't care how many people walk in front of me, like I'll still be afraid, right? But so there's this funny space in between real and not real, that manifests itself in a way that we haven't quite put our fingers on yet. And so doing it for VR researchers, we're super keen on that. But like for role play, for example, like say, oh, I don't know, like how would you react in such a situation, like microaggressions? You know, you put somebody into a situation and there's, you know, a microaggression occurs, and then they can role play in a safe space how they would react to this microaggression or this bullying situation or this, you know, like whatever it is. And because it's all make-believe, it's really easy to play out different scenarios and just sort of become comfortable with. Anyway, but it's been used. I mean, it's just 1,000 things you can do with VR. You know, some of which, you know, may be hopefully relevant to you. I don't know. But if you ever think of anything where VR.
Thank you so much. Yes, we'll come back to you, Vicki, with some ideas. We need to brainstorm, Jessica.
Yeah, I've got some notes running. This has been great.